So in the next few minutes, I'm just going to be giving a bit of an overview of BCMA-directed T-cell engagers or bispecifics for myeloma. So I'm from Melbourne, Australia, and been involved with a number of trials. I can say I've got a lot of experience with teclistamab and a little bit of experience with linvoseltamab. So this is the approved treatments and indications. And to summarise, we have teclistamab, L, and linvos. And you can see here that the EMA approval is very similar for each of the agents, greater than 3 prior lines of therapy. If you look at the FDA, it's greater than 4 prior lines of therapy, and that includes those drugs listed there. Interestingly, and as you know, teclistamab has recently been approved in the last month or so in combination with daratumumab in patients who've had one or more prior lines of therapy. In other words, can come in at second line. And I'll talk about that a little bit later. If you look on the right-hand side, it's impossible to compare the studies, particularly over the time frames when we've got better at treating some of the toxicities and different drugs have been available. But you can see the response rates listed there between the three, duration of response differences, PFSs looking a little bit different, but again, over different time frames. It's interesting to look at the CRS patterns, but again, it's around how do we treat CRS and severity, and ICANS is uniformly low. The neutropenia is important and well recognised, and infections, as you can see there, can be quite substantial. And I would argue that potentially in real world, it's with longer follow-up, it's substantially more. So, I think this is the big question: is that when do we choose which drug and when with respect to BCMA-directed therapies? So there is a number of factors, and if we look at the left-hand side, if we perhaps move around from the top in a clockwise fashion, choosing the treatment may well depend on the prior therapy. There's patient factors, including fitness. There's patients' preferences. There's strategies for lines of treatment. What are you going to do next? Playing this chess game. T-cell fitness, which really relates to what is the prior treatment that they've had, such as CAR T, and then importantly, it is around how sick is the patient, disease burden, the urgency, and that relates to the central thing, which is around access and logistics. So obviously talking about CAR T cells versus the others. And so on the right-hand side, I don't need to tell this audience here, but the two on the right, which is the CAR T and bispecifics, in other words, the immune modulating agents, there is issues around availability and the manufacturing. We also take into consideration the risk of CRS, neurotoxicity. But then you've got the BelMath, the antibody drug conjugate. It's off the shelf. It does require some repeated dosing. We've talked about the ocular toxicities, and it's less dependent, obviously, on T-cell fitness. So some important differences that impact on the left-hand side. So trying to put that, all together, when we look at the IMWG consensus guidelines, which have already been mentioned, in terms of selecting between BCMA-directed therapies, they suggested that when feasible, CAR T-cell therapy is generally preferred over other T-cell redirecting therapies. In patients with rapidly progressing disease, where you can't apheresis and bridge them, then the T-cell engagers seem to be a good choice. And when both options are available, T-cell redirecting therapies may be preferred over ADCs. In terms of sequencing, following a BCMA-directed CAR T, both BCMA-directed and non-BCMA-directed immunotherapies remain potential treatment options. And responses to the subsequent BCMA-targeted therapy are probably less frequent and less durable compared to the BCMA naive patients. And in fact, if it's been a pretty short interval, switching to an alternative mechanism of action of target, in other words, a non-BCMA target, makes sense, should be considered. So that's really setting the scene, but how can we improve on that? And what are the emerging strategies? And we already have one emerging strategy in the US where teclistamab in combination with daratumumab as second-line therapy or beyond has already been approved. And that's based on the MajesTEC-3 study in patients who had 1 to 3 prior lines of therapy with a good follow-up of 34.5 months. Median progression-free survival was not reached in the experimental arm. The 36-month progression-free survival was very impressive at 83.4 months. Overall survival wasn't reached, and you can see there in the graph that the stringent CR rate was very impressive in the Tec-Dara arm. So, an exciting combination which we'd like to have. I think one of the things about that study is, what happens if patients are relapsing directly on Dara. So investigational combinations that are being developed. There's the dual targeting approaches, BCMA plus GPRC5D or FCRH5. What about comparing it with standard backbone therapies? They're being done already with Dara, plus or minus Len, with other IMiDs, and with CELMoDs. And then going even more exploratory with there's some studies around with immune checkpoint inhibitors and other immune agonists, even studies with CD47, the Don't Eat Me. So another strategy, other than adding things on, is to use it earlier. And when patients have improved T-cell fitness, does that improve things? Then maybe we get an enhanced durable outcome lasting many years. And so if we look at teclistamab at the top, the MajesTEC studies have looked at, number one, maintenance therapy following autologous stem cell transplant. That's also being done with elranatamab at the bottom line with the magnetism 7. Then there's the transplant eligible group, which looks at teclistamab plus talquetamab. So the double bispecific antibody strategy. Then in patients where the transplant is not intended or ineligible, where again there's either teclistamab plus Dara or talquetamab plus Dara, and then there's the magnetism 6, which is in the transplant ineligible group, which is elranatamab, and patients either get Dara, lenalidomide, or just lenalidomide alone. And there's a trade-off there with benefits and toxicities. For those of you who have been involved in those studies, I think we're all interested to see what the toxicities look like in comparison to patients who've been treated further down the track. So the practical considerations are important because we want to get these drugs into patients in the community. And there are some differences between elranatamab and teclistamab. The flat dosing exists with elranatamab, where it's done by weight with teclistamab. You can see there that there's slight differences in step-up dosing. You can see that the dosing frequency is slightly different, and elranatamab at the moment goes out to Q4 weekly. Teclistamab is Q fortnightly, but we're talking about clinical trials. We do know that in the real world, that frequency is frequently adjusted outside of what was initially recommended in the clinical trials. So it is about getting it into the community, and I think it's fair to say that if we look at the delivery of these drugs, how can we divide that up? There's the initial step-up dosing, then there's the early toxicities that might occur in that first week, 2 weeks, 3 weeks. Then there's the stabilization of the toxicities, particularly during the step-up dosing. And then the patients are more comfortable in the outpatient community care environment. And I think as we learn more about these drugs, that initial phase will become earlier. The use of dexamethasone and even tocilizumab in the early phases have reduction in toxicities, bearing in mind that basically most of the toxicities occur in the first week and then less so in the second week and are quite rare after that. So we want to get into the community, which requires good protocols, good strategies, good pathways, and allow the patients to get back to home as quickly as possible. And so I think it is really important to have clear management approaches, which in this slide have divided it up into routine, emergent, or urgent. And the routine ones are ones we see all the time, often can be managed well by the nurse and protocolized. Then there's the more severe ones where patients present with fever, CRS-type symptoms, where the nurse can manage but know when to call in the physician. And then there's the urgent ones, which basically imply either CRS or infection, and where the patient needs to know what the clear action plan is. And the issue here is it's obvious to us, but it's not obvious to the patient. So they don't know what symptoms are to be worried about and what not to be worried about. And I think these action plans are really patient-focused to make sure they're educated so that they know where they're expected to go, what's expected to happen to them depending on the sort of symptoms that they have. So it seems simple to us, but needs to be well explained to the patient. And, these can be clearly divided up. And so I think as units that are delivering this, it's a nice way of looking at who's responsible for what. And you can see there that there's responsibilities from the specialist and the other specialists, such as the neurologists and the ID physicians. The nurses have a big role, the pharmacists have a big role, and the primary care physicians, have to have good support. And so, to summarise, the choice of these are guided by the disease characteristics as well as the T cell fitness, treatment access. There are subtle differences between the agents. I can't say that there's no comparative trials, and so the differences from these phase 2 data are difficult to pick which is the best one. And I think it's about using them all and determining what what you're most comfortable with. I think what we do know is that the toxicities are generally early, and it's pretty straightforward with good protocolized management to get these patients back to the community, in an efficient way. So I'll stop there. We've got some questions, I think, for discussion, and I've just, basically kick off with the first one, which is pretty much repeating myself, that there are standardized protocols. What are available? Well, there are some more published protocols developing, and I suppose I would like to ask the group: are they using recognised protocols? Are they developing their own? And how are people getting people back into the community? How quickly? Or is this generally patients being, inverted commas, hung on to for the whole of their treatment? I might just open it to the group, particularly those in maybe in Europe.
Yeah, thanks, Miles, for that nice presentation. And so just, I think there's a couple of questions there. In terms of guidelines, I mean, we follow the published guidelines that are already out there, but we've actually written our own pathway document. It's something called Embrace, and it's available on our university website. And in parallel, we're on the final draft of our British Society of Haematology guideline, which has been lifted from that. So we developed our own UK specific pathway document, which goes through managing bispecific toxicities, ambulatory care dosing, pathways, and so forth. But the bit that we've actually struggled with in my hospital is getting those patients back to the referring hospitals. So, we're getting them referred in for step-up dosing, but when we try and hand them back, there's a lot of reluctance, and we've not been able to do that very successfully. So we've ended up retaining large numbers of patients at our site, which I think could be very easily managed in the community. So that's a bit of work that we still need to do in the UK, is about getting these smaller centres comfortable and reassuring them that CRS is not going to happen outside of typically the step-up phase, and then just making sure that they can manage the infections appropriately. So that's still work in progress.
Yeah. Can I just ask, how long have you had the bispecifics in the UK?
Ooh, I think we've had them on and off for about a year now, both Tech, Elran, and then talquetamab more recently.
Yeah.
Our fourth line.
And it's been a good year. So do you think there'll be a big change in the next year or two?
Yeah, I mean, look, we're continuing to try and work with our community hospitals to get them to pick these drugs up, and I think particularly as you've alluded to, the phase 3 data which is coming out, these are going to be chalked up for approval reimbursement in the next 12 months, and so we really do need to be getting our community hospitals either to be able to do the step up, or at least to be able to take them back. And then the other bit that we need to improve on is our outpatient step-up dosing. We have a protocol in place, which is approved, but the big challenge we have, and I'd be curious what others think on the call, is the ability of having a carer 24 hours. We really struggle with that because our carers are normally working or have other commitments. So that's been our major problem there.
I might just move on to one of the other points that I thought was important, was that, are we seeing different toxicities or different impact in patients who are getting these drugs earlier? And I suppose I would only make the comment, which is that we've been involved with some frontline studies with a number of these, and there's some patients who do get, and there've been older patients who do get significant toxicities that we weren't seeing in when used further down the track. Things like hyponatremia, sudden onset of severe infection, responses to severe infections. We're seeing a lot of, we find a slightly more severity of CRS. But we've also seen some patients who develop quite early toxicities like CMV, and we monitor routinely for CMV now across the board. But even in the frontline setting, we were seeing CMV. Perhaps these patients are even more immune suppressed from that regard. I'm not sure, but I just was interested if people in the group's comments about its use up front. Is there a different profile of patient that we're seeing, or is there a different? I think it's a space that we perhaps have to watch, watch carefully in terms of toxicities.
Yeah, I think, Miles, one of the I guess the points is that the disease burden may be quite high at diagnosis compared to at relapse, and that could be a challenge in terms of the toxicities that you mentioned. And so that's something sometimes we kind of wonder whether we need to debulk them a little bit before going in with the bispecific at front line.
And I think that is another point too, is that there is a lot of, in patients that do have a heavy tumor burden, some debulking is frequently done in the community. I think the other thing that we'll learn into the future is, is there differences for some of the subgroups in terms of patients with poor prognostic disease, with extramedullary plasmacytomas, which seem, they don't do as well with the bispecifics, but are some bispecifics better than others? So I think a lot to learn.